Good evening, everyone. The League of Women Voters of Illinois is thrilled to welcome you to this evening's edition of Issues Briefing 2022. My name is Allison Hout, and it is my honor to serve as the president of the League of Women Voters of Illinois. For 102 years, the League of Women Voters has worked across the nation to empower voters and defend democracy. Our success lies in our ability to foster civic engagement and facilitate access to information. And our power rises from our local league presence in communities throughout our entire country. In Illinois, our annual issues briefing is our time to focus on the cornerstones of our mission work, seeking to educate each other and then use the knowledge and understanding to generate civic engagement and advocacy for change, and probably most importantly, voting. What we know about civic engagement and education is this: people who have information, people who are engaged, are people who are more likely to be voters. Issues briefing is really a pivot point for all of us. From here, we must take what we learn into our communities, where we will listen to understand, we will collaborate, we will educate, and we will activate others. We'll activate people to use their voice and to vote. Because it takes many voices and many votes to actually create change. So when we advocate for change, we must really be sure that we are actually being catalysts for that change. So let's educate and let's activate. Let's see more people using their voice and their vote to speak up about whatever it is that matters most to them. Tonight, as we focus on resources, pathways, and access for those facing mental health crises, I urge you to be an active listener, to ask questions, but then take it one step further. Take what you learn into your community, to your family, your friends, your neighbors, and your local League of Women Voters. Go beyond education, be a catalyst for change. Before we begin tonight, I want to remind you that our meeting is being recorded. To best view our spotlighted speakers, choose Speaker View up in the top right-hand corner of your screen. Subtitles have been enabled today. If you would like to activate, enlarge, or end the subtitles, go to the bar at the bottom of your screen. Toward the end of the session, we will have question and answer period. Please, during the session, put your questions into the chat box and put your questions as a direct message to Question Asker. League members will pose those questions to the speakers at the end of the session. Please join me in welcoming our American Sign Language interpreters for the evening, Sheila Kettering and Vera Marie Baldoza. And a huge thank you to the League of Women Voters of Illinois Board of Directors, to the entire Issues and Advocacy Committee, and to all of those who have been part of helping to bring this fantastic week of education and activation to all of us. And now, turn off all your other devices, lean in and engage. Lori Grainaway is going to be our introducer for our speakers, and she is our League of Women Voters of Illinois Specialist for Mental Health. Lori.
Good evening. Welcome to our session. We really appreciate you being here. This evening, we are going to talk about challenges and opportunities involved in creating 988, a national 3-digit number for mental health crisis. We will be joined tonight by Hugh Brady. Hugh is the legislative chair of NAMI, Illinois. NAMI is the National Alliance on Mental Illness. We are also joined by Senator Laura Fine, AJ French, CEO of A Gift of Voice, and Leanne Reinert, Deputy Director of Policy, Planning, and Innovation for the Illinois Department of Human Services, Division of Mental Health. We're going to start our session with a video that talks about the 988 crisis number, and then Leanne is going to give a short presentation, which will follow then with a panel discussion.
Imagine for a moment that a fire breaks out in your home, and in this and only put out fires at the fire station. And the only people that will come to you in the community are the police, who, though well-intentioned, are meant to provide a very different type of public service. This lack of a fire-specific response seems ridiculous, right? Of course we should have targeted services to respond to life-threatening emergencies, whether that's fire, law enforcement, or physical health. However, in many communities across America, life-threatening mental health and substance use crises are treated as an afterthought, receiving a response that's not specific to their unique needs. A 911 call dispatches the police, who most often bring the patient to a medical emergency room or jail, or allow them to remain in the community but without assessment, treatment, or support. We have a patchwork system, made up of elements designed for other purposes, that doesn't have the capacity to treat the most vulnerable in our communities, even though an estimated 20 to 25,000 individuals in crisis go to emergency departments every day in the US. So how can we improve? The only solution to delivering crisis care worthy of our communities is to build a structure specifically for mental health, substance use, and suicidal crisis that is on par with other emergency systems, like we do for medical, fire, and law enforcement. By integrating 3 core elements, we can replace the patchwork fabric of our crisis care and develop a true safety net that can serve everyone, everywhere, every time. And in the process, we can reallocate wasted financial resources to places where they can have a deep community impact. It starts with regional or statewide crisis call hubs. Call, text, and chat lines staffed by trained professionals who answer the call every time and direct people to the level of care they need. The onset of 988 is a great start. However, it will need to be supported by technology that empowers 988 to become an air traffic control for mental health and substance use crisis, enabling real-time coordination across the care spectrum. But a comprehensive crisis network cannot be built with only crisis call hubs. Additional services are necessary to ensure that a unified system of care is available when and how people need it. Services like mobile crisis outreach teams, 24/7 non-law enforcement mobile teams that go out in the community and deliver care to people wherever they are. This lessens the burden on law enforcement during situations where they're not needed and eliminates the anxiety people feel when a uniformed officer knocks on their door. And facility-based crisis receiving and short-term stabilization, facilities that say yes to every person that walks through the door, regardless of their level of need, allowing them to bypass the medical emergency departments. This not only provides specialized care to these individuals with less waiting, it also enables medical emergency departments to focus on the patients they're trained to serve, while drastically reducing wall time for police when transportation by police is warranted. With these core elements in place, mental and substance use healthcare can move out of the shadows and into the mainstream. Together, we can build an unbroken system of care that connects patients from the point of crisis to the level of care that's right for them. To learn more, visit crisisnow.com.
Okay, thank you very much, Rosemary. And before we start the presentation by Leanne, I neglected to introduce one of our presenters. We also have with us Blanca Campos. Blanca is the Vice President of Government Affairs at Community Behavioral Health Care Association of Illinois. And I apologize very much. Apparently I can't read my own handwriting. And we'll now start with Leanne's presentation.
Okay, thank you, Lori. And I apologize. I am going to turn my camera off because I've been having bandwidth issues ever since I joined. I've tried a couple different internet connections and everything continues to freeze. I'm afraid I'm gonna lose my connection completely if I try to run my camera and the PowerPoint all at the same time. So I'm gonna turn my video off now and then we'll get my screen shared, hopefully. And now I've got to get my slideshow going. Sorry, everyone. We just recently got some updates in our computer and it's messed up some of our stuff. Are you guys only seeing the slide? I want to check in and make sure you're seeing the actual slide and not the speaker view.
We don't see anything yet.
Do you see it now?
No, did you click on share?
I did. Hold on. Do it again.
I will try bringing it up and see if
No,
that.
I'm
there we
doing
go.
it again.
There we go.
You got
There we
it?
go.
Okay. And are you seeing, you're probably seeing the draft view, right? You're not seeing the slideshow yet because I had to turn it
Not
off
yet.
to turn it.
Right.
Okay.
So you wanna, that's right, click on slideshow. There you go.
Yeah.
All right.
So now you're just seeing the slide or are you seeing the speaker view?
No, we're seeing the speaker view.
All right.
Yeah.
Hold on. See it now?
There we
There
go.
you go. Bingo.
All right, there we go. All right. Good evening, everyone. My name is Leanne Reinert. I serve as Deputy Director of Policy Planning and Innovation with the Illinois Department of Human Services Division of Mental Health. I'm very glad to be with you tonight. I'm going to be talking to you about the 988 initiative. But before we do get started, I want to draw your attention to this special statement on this slide. Because of the significant amount of work that's currently underway to ensure the successful launch of 988, Vibrant, who's the operator of the National Suicide Prevention Lifeline, and the Substance Abuse and Mental Health Services Administration, we call SAMHSA, have requested that states and others refrain from any public messaging or marketing of the 988 line at this time. There is concern that people might attempt to access planned features of this system before they are ready, and that there could be a failure in the response that might lead to a lack of trust in the system overall. So until such time as the public messaging campaign around 988 begins, individuals should continue to be directed to existing resources, and that includes the 10-digit number for the Lifeline, which you see on this slide, 800-273-8255. Following the launch of 988, there's going to be a significant public messaging campaign that is currently being planned. And that will also include the sharing of promotional materials and messaging consistent with guidance from SAMHSA. So those of us that are involved in planning at the state level are walking a fine line right now. We need to be able to communicate with various audiences as we work to design a system that includes input from stakeholders, to advise legislators and other state leaders about the needs, and to work with potential service providers to ensure we are ready, while not unintentionally jeopardizing future success. Thus, I hope it's helpful and will, in terms of understanding the overall process, but will refrain from sharing this information in ways that might unintentionally result in harm to individuals in crisis. So with that, we'll get started on the real message today. I've been asked to spend about 10 minutes providing this 988 overview to ensure that everyone has a similar understanding and familiarity with the terms and processes as we move forward with tonight's panel discussion. So we'll start here with the promise of 988, which was also the name of the video that you just watched. And that promise is the opportunity to build a comprehensive crisis system that's available to anyone experiencing a mental health, substance use, or suicidal crisis anywhere in the country at the time that the crisis is occurring. This opportunity was first recognized as the 988 legislation was enacted by Congress, effective July 16th, 2022. A nationwide 3-digit number, 988, will connect callers to the existing National Suicide Prevention Hotline, which is referred to as the Lifeline. It will provide direct access to trained call takers for anyone experiencing a mental health, substance use, or suicidal crisis anywhere in the US at any time. When people call, text, or chat 988, they will be connected to these trained call takers. Sorry, my video keeps covering up my screen. They will be connected to trained call takers that are part of the existing National Suicide Prevention Lifeline Network. Vibrant Emotional Health is the nonprofit administrator of the Lifeline. These trained call takers will listen to callers, understand how their problems are affecting them, provide support, and connect them to resources if necessary. The Lifeline's network of over 180 crisis centers has been in operation since 2005. Counselors at these local centers answer contacts the Lifeline receives every day. Numerous studies show that callers feel less suicidal, depressed, overwhelmed, and more hopeful after speaking with a Lifeline counselor. The current Lifeline phone number will always remain available to people in emotional distress or suicidal crisis, even after 988 is launched nationally. The intention of the short code is to make access easier, with the easier to remember number and standardizing the quality and approach to crisis response across the nation. Thus, 988 will serve as a core component of crisis care in the country, consistent with the Meeting Needs, Saving Lives initiative of SAMHSA. With this easier to remember number, as well as the expanded focus and intended messaging around this expansion, it's anticipated that the overall volume of calls to the Lifeline will increase, perhaps exponentially, over the next few years. So states across the country are preparing for this anticipated increase in volume of calls, as well as an overall increased demand on the full continuum of crisis care. So while I'm going to focus primarily on the 988 specific work, it's important to understand that there's also a significant level of planning, both within Illinois as well as nationally, on the developing and strengthening of the larger crisis continuum, which I will address further in a bit. It's also important to note that while the launch of 988, sorry about that, is set for July 16th. Sorry, I am really having some issues with this computer. I'm sorry. Okay. Sorry about that. Totally lost my place. Okay. The launch is not going to change everything immediately in July. The expectation is that 988 will be a catalyst that will result in an evolution of crisis service prevention, including a redistribution of resources over the next 5 years or so. But before we talk about the larger continuum, let's focus on what currently exists in Illinois. 35 of 102 counties now have direct local telephone call coverage from a Lifeline crisis network provider. 17 of those counties have a center that provides 24/7, 365 coverage. None of our centers yet has text or chat capacity. Among the 17 counties that Vibrant established a contract for coverage, one center that covers 6 counties had to go offline for a year due to remote work conditions and Vibrant determining their technology was not sufficient with their remote at-home workers. All calls that would have come in from those counties were routed directly to national out-of-state backup centers. In the city of Chicago, only 14 of 85 zip codes have any current level of direct local coverage, and the center providing that coverage only operates during business hours. This has resulted in a current state response rate of only 19% of calls from Illinoisans currently being answered by these call centers. Again, it is important to note that a national backup network exists, and so no calls are going unanswered. They are rolled to the national backup centers and handled there. However, the more ideal situation would be for call centers that are local to the state to answer the calls for residents of the state, as the local call takers are more familiar with resources, cultural needs, and other variables that may impact individuals within our state. Thus, a primary focus for our 988 work right now is to increase the capacity and therefore the response rate of the Illinois call centers. This slide provides a visual of the three pillars of the crisis continuum consistent with SAMHSA's model, and this is what was referenced in the video that you watched. Someone to call, which is the 988 call centers, someone to respond, which are mobile crisis teams, and somewhere to go, crisis stabilization centers. Most states, including Illinois, are continuing to work to develop and strengthen all of these pillars. It's not expected that there will be a complete continuum in existence when 988 goes live. When adequately staffed and resourced, it's expected that 988 call takers will resolve between 70 and 90% of the crises through telephone intervention alone. This is an important note because of the similar 3-digit code, many people equate 988 to 911. However, this is inaccurate. 988 is actually telehealth, and the call takers are first responders. While there is an expectation of dispatch capacity when that is needed, it is not expected to be the majority of the role for 988. Then the next most intensive level, someone to respond, is expected to resolve the majority of the remaining crises without a need for a higher level of care. In Illinois, we've made significant progress through our program 590, which we call the Crisis Care Continuum, with 68 contracted providers across the state who are in various phases right now of developing crisis response. The pillar that we've not yet fully addressed is somewhere to go, or crisis stabilization centers. DMH has successfully launched 21 living room programs across the state, but most of those are not yet operating 24/7, 365. Also, these programs do not have the full array of clinical services that model programs that use a police drop-off and a no wrong door approach would have. There is one center that approaches this model. It's operated in Rockford by Rosecrans. We hope to develop more of these across the state in coming years in order to realize the full promise of 988. This slide further illustrates the concept of how the delivery of crisis care in the US is expected to evolve with 988. The graphic comes from Crisis Now and shows the overall thinking about a shifting approach, which is intended to provide better care and with it a projected subsequent cost savings given an adequately resourced crisis continuum. Again, the intention is that the majority of individuals that experience a mental health crisis, if provided with appropriately trained and adequately resourced staff at the time of the crisis, do not actually need what we refer to as deep end services. Projections have been done at the national level by this Crisis Now organization, which holds weekly stakeholder meetings and does a lot of advocacy at the national level on the needs of the system. So in this model, it's projected that the 988 call center would resolve 90% of crises without need for any further intervention, meaning that the crisis would be resolved over the phone through the 988 trained call taker. The other percentages are of that remaining percent. So of the 10% of individuals requiring more, 75% of those could have their needs met by the mobile crisis team. And of that remaining 25% of the 10%, 65% could be treated through a 23-hour or less safe setting. And 66% of that remainder could have its needs resolved in subacute crisis hospital. So for easier math, if you use a base of 1,000 people, 900 would be handled through the call center alone, 75 would need a mobile crisis team, 16 would need 23-hour crisis stabilization, 6 would require subacute crisis hospital, and only 3 would actually require inpatient care. I know that was a lot of numbers. This slide illustrates the experience for the person, and it's based on a middle of the road estimate of resolution without higher level intervention. It also incorporates the traditional 911 dispatched emergency services, indicating how some of those may be replaced by the 988 crisis continuum in some instances. This better explains the theory of a cost shift from 911 and law enforcement to the mental health crisis system at various intercepts as the systems are built out over time. Over the next few months, DMH, along with our consultants and academic partner, working with the Illinois Department of Public Health and the statewide 911 administrator, expect to convene the statewide and regional committees the Community Emergency Services and Support Act to coordinate planning across the 11 911 regions in the state to ensure protocols are in place to guide the 988 centers in when to contact our mobile crisis teams and which team is to be contacted. The Illinois General Assembly passed House Bill 2784, the Community Emergency Services and Support Act, during the spring 21 session, and Governor Pritzker signed it into law this past summer. The stated intent of the legislation, also referred to as the Stefan Edward Watts Act, is to provide emergency response with or without medical transportation to individuals requiring mental health or behavioral health services in a manner that is substantially equivalent to the response already provided to individuals who require emergency physical health care. The goal is, whenever capacity exists and it is legally and medically appropriate given assessed risk level, to first allow mental health providers to serve as initial responders in situations where an individual presents with a behavioral health crisis. The entry point into this behavioral health first response can be 911 or 988, which is the number we're talking about tonight. Or it could be, calling just a local mental health center. The behavioral health first responders for these crises will include the mobile crisis response teams that are housed within our community-based behavioral health providers across the state who are receiving Program 590 funds to develop those teams. CESA created a statewide advisory committee that's tasked with reviewing and making recommendations for aspects of coordinating 911 and 988 to achieve the intent of the legislation. The statewide advisory committee will serve as the oversight and governance structure for the implementation of the legislation under the auspices of the Secretary of DHS. And in addition, there will be 11 regional committees that correspond with the 11 EMS regions overseen by the Department of Public Health and the emergency medical directors who are responsible for the protocols for operation of 911. Finally, we created the 988 planning page on the DHS website very early in this work, and it continues to be the first place I refer people who are interested in learning more. In addition to the resources that we share with the coalition from the beginning of planning, we have additional materials from federal sources. We even have the link to the video you watched tonight and other references that assist in understanding the complexities of this endeavor. And we now have a link where visitors can request to automatically be added to email lists about 988 or CESA or both. Then we also continue to hold our stakeholder coalition meetings. They used to be monthly when we were doing our planning. They're now being held on a quarterly basis. The next one will be in June. We just had one this week. All of those are held as public meetings. The links are posted on the planning page. Anyone is welcome to join those meetings. We're currently in the process of working through nomination and appointment process for statewide. CESA membership will be followed very, very quickly by the regional nominations. We're already receiving names of those interested, but are continuing to look for additional parties. So if there's lots of opportunities to become involved, and anyone that wishes to become involved can go to the page, send us an email, and we will add you to our lists. And with that, I will turn it back over to you. Thank you.
Thank you. Now I'm going to introduce Hugh Brady, who is going to be our moderator for the evening. This is going to work something like a political format. Hugh will ask a question to an individual, and then others on our panel will be welcome to respond as well. So Hugh, it's all yours. You're still muted.
There we go. Well, good evening, everybody, and thank you for being here. We have a whole series of questions, so let's just jump right in. The first question is for Senator Fine. This three-level system of a call center and a mobile crisis response team and crisis Intervention centers is going to cost a lot of money. How's it going to be funded?
And that's a really good question. So I want to thank you for having me tonight, and thank you for really focusing in on what I think is a very exciting and life-saving opportunity for so many people in the state of Illinois. So I would say the funding for this is a bit complex. Originally, the Illinois Department of Human Services was awarded a grant from Vibrant, who's the operator of the National Suicide Prevention Lifeline, to plan for the implementation of 988. The future funding is going to come through a variety of sources: federal, state, trust funds. The governor's budget proposed $5 million for the trust fund and $5 million in grants for call centers. So like I said, there's a variety of funding where it's going to come from, and all are designed to make sure that the program is a success.
So if I'm recalling correctly, the governor had proposed $120 million for community mental health centers for, is that going to be part of this system?
I'm not quite sure how that money is going to be divided up quite yet. I was very excited that the governor did talk about $120 million for community behavioral health in his budget. Of course, I'm going to ask for more than that, but we'll see where we end up. And it's all a part of it because it's all part of the entire process.
Okay, and a question for Blanca, or excuse me, question for Leanne. So once the system is up and running, who will answer the phone calls, and what kind of training will they have, to respond to the callers?
Sure. So as far as the 988 call centers go, every person that is working within a 988 call center is required to undergo a specific amount of training. They include folks that we typically refer to as like mental health professionals, crisis counselors. Also, an important part of call center operations are individuals with lived expertise. So individuals who have experienced mental health or substance use challenges themselves, or perhaps loss from suicide themselves. All are considered part of that lived expertise, and are also eligible to receive the training and work as call takers.
And these will be paid positions. They're not volunteers.
Well, the Division of Mental Health is funding a statewide call center where call takers are paid. Right now, there are many Lifeline call centers. Remember, they've been operating since 2005 across the country. There are many that do use volunteers. That's a model that has worked for years. But given the increased expected volume, we don't think that building a system that relies on volunteer workforce is reliable. And so we are in the process of developing contractual relationships to ensure that we've got adequate support to respond to Illinoisans within Illinois.
Great. And just as Lori announced, that if any one of the other panelists wants to jump in on any of the questions, go ahead. If not, I'm going to jump a question for Blanca. What are the current treatment needs and available options, before 988 even becomes operational?
Yeah, thank you so much for having me. So our association, the Community Behavioral Health Association, represents safety net mental health and substance use providers, and they provide services across the continuum. So we're, work with children, adults, and families. So in terms of the crisis continuum that we're developing, our members will be the teams dispatched when an on-site response is needed. So that's a perspective I'm coming from. So our providers are boots on the ground. They're seeing the reality. We know that during the pandemic across the country, anxiety, depression, and ED visits for drug overdose and suicide attempts rose. In Illinois, nearly 1,000 individuals took their own lives in the first 3 quarters of 2020. Our state has the 6th highest rate of suicide for Black youth in the nation. And in 2020, there were 2,944 fatalities due to opioid overdose, representing a 32.7% increase from 2019. So that is the current situation. So the need has significantly increased, but because our behavioral health system has been underfunded for so long, we don't have the capacity in the community. We don't have enough behavioral health professionals in the state or across the country to meet the demand for services. So as we're building the crisis infrastructure, it is equally important to strengthen our community-based services and supports to ensure that folks get connected to the appropriate level of care in a timely manner. So that is the current situation in terms of the treatment needs and options.
And just a follow-up, what will change then once the system is up and funded?
What will change? So I think the possibilities are just amazing, and the opportunities are really huge for 988. There's this heightened concern, awareness, I should say, a heightened awareness across the country, within our state government, at the federal level, about the need to really invest in our crisis infrastructure, but as well as, again, that community support services. So what happens after the crisis, right? Those supports need to be there in the community to ensure that we don't have folks cycling through this crisis continuum. So I think that's what's going to change. The governor did include, as you mentioned, Hugh, and as Senator Fine noted, we are seeing historic proposed investments in behavioral health care in the budget. He actually was $140 million for behavioral health rate enhancements. As I mentioned, our system has been underfunded, and that is the reason why we have capacity issues, why we have significant workforce issues, even prior to 2020. And then it was about $70 million for the 988, for building the 988. And we know that this is kind of like a down payment, right? We need sustainable funding to ensure that we do have a system that is sustained long-term. So what that looks like in the future, I think there's going to be, as Senator Fine mentioned, federal monies. There is some opportunities. The federal legislation did allow states to impose a fee on telecom providers. Our state hasn't moved in that direction, but there is that option as well. So there's a lot of various ways that we can fund this, but I think the main point here is to ensure that there is sustainable funding for the crisis continuum and those for those follow-up services.
Great. And a question for AJ. What will be the role in this whole process for people who have a lived experience with mental health or substance abuse problems?
Thanks, Hugh. I appreciate the question and appreciate being invited today. For those of you who are wondering, camera's not broken. I'm just a little bit camera shy. So I thank you for listening to the sound of my voice. And I want to just start off by saying, you know, I think that one of the most obvious roles is that in this education forum, in a forum that was put on by a public entity, we have somebody like myself, somebody who has attempted suicide many, many times, and who has also lost people to suicide, that's participating as a key stakeholder. So I think that's incredibly important. Nothing about us without us. But in terms of I've kind of structured this like, well, what's on the front bumper, what's in the body of the vehicle, and what's on the back bumper. So on the front bumper, there are key stakeholders that have that personal experience as a suicide attempt survivor and a suicide loss survivor. We do have two organizations that heavily employ people in recovery that's been contracted by the state to train the call centers. So that's especially important. In terms of like what's in the middle, what's in the body of the vehicle, the engagement specialist. In Leanne's presentation, she talked about three things that are really kind of key to remember a very big and complex system: someone to call, someone to respond, and somewhere to go. So in the terms of the response, the mobile crisis teams that are responding, having engagement specialists, there are people that have obtained the CRSS credential, the Certified Recovery Support Specialist credential, or they'll be hired with an expectation of obtaining this credential within 1 year of their hire. For those not familiar with that credential, the CRSS credential is a credential that's earned by people with mental health challenges or co-occurring mental health and substance use recovery challenges. And it's not given to somebody because they have a diagnosis or because they've overcome sometimes incredibly daunting circumstances in their lives. It's earned by people who are people in recovery who have had 2,000 hours of supervised work experience, which is the equivalent of 1 year of full-time employment. And also 100 hours of recovery education experience. They abide by a professional human service code of ethics, and they're willing to disclose their experiences for the purpose of benefiting and supporting somebody else's recovery and for the purpose of improving human service systems. So having those engagement specialists, the research has just shown that when you work with a person in recovery, it actually minimizes the need for psychiatric medication. It minimizes the need for psychiatric hospitalizations. So there's a lot of research behind peer specialists. This title will be engagement specialist. Partnering with a clinician, that's just really, that's a good partnership. In terms of what's on the back bumper, another role is that I apologize. And this is just something that I would like to see. I would like to see for the states to actually contract with Centers for Independent Living and prosumer or peer-delivered organizations like Gift of Voice or GROW or Davis Integrated Services to conduct caller satisfaction surveys. It's really important that persons with psychiatric disabilities and persons that are deaf and hard of hearing and other co-occurring conditions as well, that there be an accountability component, even to have peer researchers. There's some nationally known researchers, some from the state of Illinois and some from other places like Nev Jones and Tracy Jones and Patrick Corrigan. To have people to conduct that research would be really helpful, just ensuring that we don't it's not just the front bumper in the middle, but that we, within the 5 years anticipated will be fully functional date, that we really have delivered the best possible package. Thank you.
Great, thank you. So this kind of grows out of what AJ was talking about with, national sorts of things. But a question for Senator Fine. Will all the states be launching 988 at the same time and in the same way, or is it staggered, or how does that all work?
So all states are required to launch 988 by July 16th. So what is that, about 4 months from now? And I would say some states are more ready than other states are. What is going to be exciting is when it is underway, many states will have not only calling capabilities, but also texting capabilities. Some people are just more comfortable with that form of communication. Every state did receive some federal funding through ARPA to help support the 988 workforce, which is so important. But it's going to be up to the individual states. So every state is going to be doing it a little bit differently. And I think a challenge that many states are going to have right now is a challenge that we're seeing in Illinois, but it's also nationwide, and it's staffing. And how do we make sure that we have the properly trained people to fill these positions?
Yes, great. So this question is actually probably ought to go to Leanne. So could you outline again what happens after the call? Somebody calls 988 once the system's up and running. Somebody calls 988, and then what's next?
So again, the majority of time, it's expected that when somebody calls 988, they will get their needs met, that the call taker will provide them with a service over the phone, a telehealth service, and their crisis will be resolved. For the smaller percentages whose crisis is not resolved immediately, the 988 call takers
Again, once the system is functioning and all linked together, we'll have access to the mobile crisis response teams. They'll be able to call the mobile crisis response team in the area where the person is at and send someone to that person where they are to provide face-to-face crisis intervention services. And then if that's still not enough, or if it's determined by the risk assessment that goes on by the call taker with the person on the phone, that the person needs to be in a safe place, then they can assist the person in getting to a safe place. A crisis receiving stabilization unit would be the ideal place. And so that's how the immediate crisis will be resolved, either through the call, through someone going to them, or them going to a place that's safe. Then following that, it is also, Blanca said this before, we don't just need crisis response, we need a continuum of services. And so we know that for folks who experience a crisis and then receive adequate follow-up care, that they're 85% chance that they will not require higher level of care. And so there will be resources available to the call takers to link individuals with ongoing services if that's what they need. And every call center is required to offer a follow-up call. So again, for folks that maybe are having suicidal thoughts and their immediate suicidal crisis is resolved through that initial call, research shows that it is still a best practice to offer a follow-up call. So within a period of time, 2 to 3 days, you offer to call the person back and just check in and see how they're doing. If they're still doing well, if the plan that you came up with together is working, if they need to tweak that. So you have a counselor call them back within 2 to 3 days. And so every caller who calls into 988 and has their immediate crisis resolved will also be offered that option of a follow-up call.
So this is sort of a related question, but I remember when the shooting, the horrible shooting happened at NIU, Northern Illinois University, 10 years ago. Afterwards, there were stories that a lot of the shooter's friends knew something was terribly wrong, but didn't know what to do. So can somebody else call the 988 for someone else, or does it have to be the person in crisis making the call?
So a person could call for someone else to 988, and the 988 call taker could talk with them about resources that are available. This system really is more about providing the telehealth response directly to the person. But certainly the call takers will have at their fingertips resources and the ability to talk with a person about what options are available if they're concerned about another person. Yeah. Also, that's kind of true with kids too, right? The kid child, adolescent, there are slightly different interventions that are planned for the child and adolescent population. And actually, SAMHSA realized that the toolkit that they released a couple years ago that all the states have been using as our Bible as we're building this 3-pillar system was really focused on the adult system and how adults need supports in crisis. And so SAMHSA has been working for several months now with a variety of stakeholders and experts. And just this month, they're going to be rolling out a modified crisis toolkit for children and adolescents. So we'll see pretty soon kind of what those modifications are. But one of those is it may not be a child or adolescent calling for themselves to 988. It may be a parent. So how do you help the parent? Yeah.
Okay, great. Thank you. So so maybe Blanca, a question for Blanca, if you could give a kind of an overview about how this will, how 988 will improve what we already have.
How it's going to improve what we already have. So I think there's a lot of work that needs to go with this, a lot of work. But thankfully, we have Senator Fine on here. She is just so amazing and has been such a strong behavioral health champion in the legislature. DMH, our partners at DMH, HFS have also been very supportive. And then we have many advocates who are working and very committed to strengthening the behavioral health system. And again, I mentioned in the FY23 proposed budget by Governor Pritzker, we are seeing historic investments in behavioral health. And I think partly it's due, right, to the increase in need that we're seeing because of COVID, the building of this crisis infrastructure. We also have different programs that we're building as a state for children with serious behavioral health issues. So really, I think the end goal is to have a complete continuum of care so that communities across the state have the services that people need to get to a healthy place. So I think we're moving in that direction, both at the state level and at the federal level, in our conversations with our partners from other states and our partners who are national partners. They're also talking about they've never seen the number of hearings on mental health at the federal level. And this issue is it's a bipartisan issue. It is not a partisan issue. Going to Senator Fine's committee, going to the Mental Health Committee in the House, you can't tell Republicans from Democrats apart. There is strong support for this for behavioral health across the board. So I think there's huge opportunity to really beef up services. Bringing this issue, behavioral health is part of healthcare, and I think we're seeing that, people are realizing that, and now it's not just a talking point, they're actually moving forward and investing to ensure that it is on par with physical health. So I think we are moving in a very positive direction, and people, I'm very hopeful that people are indeed going to get the help that they have needed, some people, for a really long time.
Right. Did anybody else want to jump in on that? Okay.
I would like to say just one more thing. The other thing that I think is important is, and I'm from the mental health side of things, so I always think about it that way, but the fact that we're also talking about substance use as a crisis is really important, because we've never had a substance use crisis approach before. In terms of crisis theory, says that when a person is in crisis, that's the time to intervene with them. They're motivated right then. And so if a person has a substance use problem and it's 3 a.m. and at 3 a.m. they want to talk to someone about how they get help, they need someone at 3 a.m. to talk to. And that's not how our system's designed right now. And so the fact that 988 is focused not just on mental health or not just on suicide, but on folks that for them, what they experience as a crisis is able to be addressed in the moment, that means they are much more likely to benefit from that intervention and not need further care.
Yeah, so I go ahead, Senator Fine.
Yeah, I just want to add something to that. Blanca sells herself short. She's like the mastermind behind getting everything done, and it's such a pleasure to work with her. But what both Blanca and Leanne said, it really comes to the core of what's taking place with 988, that mental health is an illness and it's not a crime. And finally, our society has come around to say that we are going to treat people who have mental health issues as a health issue. And so many people are going to benefit from everything Illinois is doing, everything from the federal government is doing to make sure that people get the help they need with this crisis hotline.
Yeah, so that reminds me of, you see at various mental health advocacy groups, you see either a t-shirt or a button that says treatment works if you can get it. And so maybe this will be the catalyst to make it so more people can get it. So a question for AJ, how do you think 988 is going to interact or change the legal system, things like confidentiality and all of that?
Mm-hmm. When I hear the words legal system, I think of the criminal justice system. I think of a set of legalities, and what I hope will happen is that it'll strengthen public trust, both in helping professions and also in law enforcement and public safety. just kind of to piggyback on some of the conversation that was just had. We know that once upon a time there was a war on drugs, and now it's like viewed as an opioid epidemic. So seeing mental health challenges, mental health crises, and substance use crisis actually as a crisis, I think that would be good. I was on a call, I think it was no, it was not just yesterday. It was within the last week. And it was made known to me that the 911 system, the origins of that actually started in racism, that it was a way for people to call the police and there be call the police on African Americans, and African Americans would be caught in this legal trap. And I'm so glad that just seems like such a sharp contrast compared to what is trying to be established this time. So I hope that we can strengthen public trust for a number of groups, not just cultures other than white or Caucasian, but also for, the helping professions have not always helped us. And we want to make that better. Every person on this call, whether it's a panelist or somebody just listening in, we're on this call for a reason. Like, we want to make things better. So I hope we can strengthen public trust. And I hope that death rates from persons having psychiatric disabilities, hearing disabilities, and persons of color, I hope those death rates, when there is involvement with law enforcement, I hope they decrease. I hope they go down. I hope that we actually can trust our public safety, our law enforcement. I hope we can trust our helping professions. I hope the recidivism rate will go down. I hope that and not just recidivism, but actually incarceration. If we could employ people with the CRSS credential within the court system. And I know there's a couple counties it's at least one county that's done it, and one county that's utilizing interns, it's like hot off the press. They're going to be doing it at the beginning of April. If we could do that at the courts. I know that I think it's the state of, I want to say Michigan. I hope that's not right. I always get Michigan and Wisconsin mixed up for some reason, but I think it's Michigan. There's a Watonoo County. There's a sheriff there that actually employs, they don't have the CRSS credential in their state, but the equivalent of that credential, they actually employ people to work hand in hand with police officers. So I would like to see, I think that's a way that, across that whole legal system, whether a person is arrested or they're in the court system, or they're on probation or parole or incarcerated, and then we're looking at recidivism when they re-enter. I hope that so many of those things will decrease. And I know that just yesterday there was this session on, how can people with arrest records become fully free? Is there a way that people can access the healthcare services and supports that they need without even becoming unfree, without losing their freedom? I'm also hoping that people will be a little bit more likely to call 988, knowing that the police response is not automatic and that it's anticipated it'll be minimal. There's all kinds of reasons why people don't call. I'm hoping that we heard earlier about there's many voices needed to create change. I'm hoping that continuum of services and the historic investment that was referenced earlier, I hope they begin to include prosumer and peer delivered entities as supports. I know that in fiscal year 16, as part of the budget cuts, there was over $800,000 for a prosumer organization. It was eliminated from the budget and they've never been reinstated. And then also, when the GATA legislation was passed, and it was for a good purpose. I understand the purpose of that legislation, but it eliminated the ability for the directors of the Department of Human Services, at least for the Division of Mental Health, and for the Division of Substance Use Prevention and Recovery, although back then it was referred to as DASA. They had some discretionary funds that they could fund peer organizations with. And now, though that's because of the GATA legislation, that's not happening. So I think on one hand, it's like, oh my goodness, this process has been so inclusive of people with lived expertise in, I believe, unprecedented capacities. And on the other hand, we still have a little bit further to go. We still have a little bit more to show that people with lived expertise who work for organizations that are operated by people in recovery are full-fledged partners at the table. Thank you.
So just imagining somebody in the midst of a mental health crisis, it would certainly be less alarming to them to have a social worker and a CRSS certified person knock on their door instead of 3 squad cars with lights flashing and armed police officers. So it was kind of relevant to what AJ was saying. Blanca, how do you think 988 is going to work and affect folks in Black and Brown and other minority communities?
Well, I'm really going to echo a lot of the things that AJ said and have been said. So 988 is just vital for supporting marginalized and disenfranchised populations who are unfortunately disproportionately most at risk for police interactions turning deadly or of incarceration. So as you just said, Hugh, just having a MCR team made up of a mental health professional and a person with a lived experience instead of a law enforcement response, when appropriate, of course, has the potential to save lives, plain and simple, and most importantly, with 988, right? So especially for our communities of color. And again, it also moves us away from criminalizing behavioral health care, and as Senator Fine mentioned, treating it as a health issue, which it is. And then as Leanne mentioned, 988, the 988 call centers will have information on local resources, including mental health, substance use, services, and other community supports. So connecting Black and Brown communities with culturally appropriate resources, very importantly, will help increase the likelihood for engagement and further positive impact on our communities of color. So really echoing everything that everyone said.
So I guess there's a follow-up for Blanca or maybe Leanne, will the 988 operator call receivers, will they be able actually to set up an appointment? Say somebody, well, your local community mental health center is Alexian Brothers, and I'm on their computer, and one of their social workers is going to call you on Wednesday and have you come in? Or is it just going to be, here's a number you can call? And a warm handoff or just a list of resources?
Yeah, so that's the vision, right? Is that everything will be connected and the call takers will have every resource they need. But that's why we're saying it's probably going to take 5 years to realize the full potential, is because those systems in our state don't exist right now. And Vibrant, the operator of the Suicide Prevention Lifeline, is in the process right now of developing a platform called a unified platform that will allow for that type of access to databases and information sharing. It's going to evolve over time as well. So all of this is a work in progress, and but that's again why we don't want to promote before it's ready. Because we don't want people to think that they're calling 988 to get one thing and then that thing is not available. So I think that's really important. And I just wanted to go back for just a second to this whole thought about, reducing incarceration and the promise of the mobile crisis response and what that really means. And just, all of this is based, SAMHSA's model is based in a lot of research. Places where this is happening already, it works. In cities where they have adequate mobile crisis response teams, 97% of the time, they don't ever need to call law enforcement. And we know that when a person with a mental health or a substance use crisis has 911 called on them and law enforcement responds, particularly if that person is in a Black or Brown community, that the chances for adverse outcomes is really high. And so the promise of a mobile crisis response to provide the appropriate types of care that's not what police do. It's not what they're trained to do. It's not what they're intended to do. So let's get the people out there that are trained and can do what needs to happen for that person. And that results in less institutionalization. People don't end up in the hospital. They don't end up in jail. If you're Black or brown, you're more likely to go to jail if you have a mental health crisis and the police are called, where if you're in a white community, you're more likely to be taken to a hospital. But both of those things are institutions that are expensive to the system, and they're not necessarily the best response for the person. So let's get the person the best response that research shows actually helps and gets them back living a life that they choose to live.
So you mentioned a couple of times the SAMHSA Bible. I think you mentioned this big document from SAMHSA about how to do all this stuff. Is that guiding you, or are you finding things in there that you think, what? That doesn't sound right, or is it pretty good? Or
yeah, it's really good. Like I said, it's all research based. It's over 300 pages. So for anyone who wants to read it, it's linked on our 988 planning page that I had put in the slides. Yeah, it's all evidence based. States across the country are using it. It's based on things that some states are already doing. You know, I'd love to say we've got the best here of every single type of program, but we're still in the development phase and we're learning from other states. And other states are learning from us too. So yeah, it's evidence-based, emerging best practices, and definitely shows a lot of promise.
So one little question came up, kind of probably a small number of people, but how will calls be handled for those with hearing disabilities? I guess that would go to, I don't know, Leanne, I guess you're the person in charge of that.
Well, so right now, people with that are deaf or that have hearing disabilities, hearing loss, call the Lifeline right now, and they call through a relay center, and an interpreter is involved in talking with the call takers. True for individuals that speak other languages as well. There's 170 languages that interpreters are available within 60 seconds for the call center. So they link in the translator or the relay person, and they can serve anyone that needs the assistance.
So would that be like through some sort of a, you know, somebody needed to do sign language or texting, I suppose, or sign language through some sort of video hookup, like a Zoom call that we're on, or?
So that's also kind of one of those improvements that's being talked about, and there's at the national level, there are talks going on right now. I'm in federal calls every single week about this. You know, there's debate about, is it better for the person to have their local call center or a call center where they can see the screen and actually sign with another person? So, you know, that's still kind of in development or in the debate stage, what will happen. Yeah.
Okay, we've got some questions that have been submitted. So let's start. We'll jump right in. The first one is, I don't know if you're familiar with this, but in Lake County, there is a 211 phone number. So in areas where there are other services available, how is the 988 phone number going to be integrated with these other services? And I have no idea who is the best person to answer.
I can do it, but I feel like I've been talking a lot. So I was waiting to see if anyone else can raise their hand. So yes, 211 is currently available in 49 states out of 49 counties out of 102 in Illinois. And our statewide call center is being developed by a 211 vendor. 211 is a set of information about various human service type resources, and folks can call and ask for assistance. So the vision is, at least especially for us, because we have a 211 center that's developing our statewide call center, is that that type of resources would also be available to the 988 call taker. And that's also part of what the unified platform may be capable of doing, is providing additional sets of resources. So the difference is a 211 call taker is not trained to handle a mental health or a substance use crisis or someone with suicidal thoughts, but they do have other resources at their fingertips, and our plan is for our 988 call takers to have similar resources at their fingertips.
Okay. Speaking of not having professionals, so one of the questions is, those of us that are involved with mental health know that there's not enough mental health professionals now. And the talk is, from what I'm gathering from the presentation, you're going to need a lot more individuals to man these call centers. I mean, we just need more people in the mental health field. So what's the plan in place to have these people?
If I can interject here. So I have been working on, for many, many months now, a piece of legislation with the community behavioral health community, with NAMI, with all sorts of behavioral health professionals across the state. And we passed through the Senate an omnibus bill that focuses exactly on this issue. How do we grow the workforce in Illinois? And this bill does a number of things. It makes it easier for professionals working in other states to get licensed in Illinois. If you're in Illinois and you've been out of the workforce for less than 5 years, it makes it easier to get back into the workforce. It also does something that's, I think, really important, is it encourages people to hire individuals who are in recovery from a mental health issue or a substance use disorder by giving them a tax credit for hiring people. So we're trying to think of creative ways of what can we do in Illinois to really grow the mental health professional field. And we're hoping that this piece of legislation is a benefit to that, and that we're able to see more and more people enter this field.
Do you know the bill number offhand?
SB 3617.
Okay.
And also, just to piggyback on what Senator Fine just said, there also a few other initiatives that we had worked on. The Behavioral Health Workforce Education Center that passed a couple of years ago, and that will be funded thanks to Senator Fine's advocacy and to DMH. That center will be funded. It really is to build a pipeline of behavioral health professionals. A lot of the data pieces were missing. So workforce development and planning will be the focus of that center. So that should launch in early 2023. There's also loan repayment for behavioral health professionals that we passed a couple of years ago. Again, thanks to Senator Fine and DMH, that will be funded this year at $5 million. So that program is scheduled to launch in July. And again, this budget includes significant funding for healthcare across the board, including behavioral health. The proposed budget, I should say, includes funding for our workforce. So again, there's a lot of strong support to ensure that we, chip away. As Senator Fine, there's so many things that it's a big problem. So we're doing a lot of things to chip away at it and improve the situation, so that again, folks indeed have access to, really critical services.
And if I remember correctly, that behavioral education workforce center, is that being run out of the University of Illinois?
Yes, it's the University of Illinois and Southern Illinois University will be the two universities that are going to be the leads on that. So I'm just very excited to hear that it's very promising. It's modeled after the Behavioral Health Education Center of Nebraska, who have seen significant improvements in their workforce recruitment and retention strategies. I think they've seen at this point, I think it's a 30% increase in their behavioral health workforce, over 30%, pretty significant, when the majority of the states we're still seeing emergency level crisis. And again, everything's been exacerbated because of COVID. So it's gotten worse.
This is AJ. I'd also like to share that in regards to CRSS workforce development, the state of Illinois recently awarded approximately $8 million to schools and universities in northern, central, and southern Illinois. I believe the total number was 11. And it's specifically for the purpose of providing the recovery education and some of the internship hours needed to prepare people to prepare students to sit for that CRSS exam. And the CRSS is maintained by the Illinois Certification Board. And just really the timing is ideal in terms of the field of recovery support and peer support is exploding exponentially with the engagement specialists, but really any entity that provides anybody who's in the people business, whether that's housing, whether that's providing, shelter for domestic violence, even on transportation systems. A lot of times, people take the bus, or in near Madison County, Illinois, it's the Metrolink. And who gets called when there is a mental health crisis? So being able to have a 988 system and having right now there, if you go like on Indeed.com or Monster.com, there are more positions available for recovery support specialists and peer support specialists than there are qualified candidates to fill those positions. So
that
that's
is really encouraging to hear. And I do want to thank all of our panelists for sharing this valuable information with us today. And also thank you to our league members and friends for staying informed and engaged in advocacy. Now, please stick around to complete a brief evaluation poll. If you wish, we will keep the session open for 10 minutes so you can exchange chats with others. And if you raise your hand electronically, we'll unmute you and you can speak to everyone. We do not expect our speakers to stick around, but this has been fascinating. And so you're more than welcome to stick around for another 10 minutes, but that's totally your decision. And then please do join us tomorrow at noon for our next issues briefing session, Immigration Issues at the Federal and State Level, featuring Fred Sau from the Illinois Coalition for Immigrant and Refugee Rights. Thank you to all of you.
Okay, I'm going to stop the recording.